Здравейте! Добре дошли в днешния вебинар.
Hello everyone. Welcome to our webinar. It's a joint effort of the Zemiata and the Health Effects Institute. Today we're going to speak about traffic, air and health. What more do we need to know? My name is Dragomira. I'm in charge of the topic of air quality, and I'm very happy that today we will be joined by two lecturers from the Health Effects Institute in Boston, the USA. These are Pallavi Pal and Hannah Bogart. They are going to tell us more about two of the more important reports they have worked on. They will focus on traffic-related air pollution and the health effects thereof. And the second one has to do with health effects on human health in big cities in Southeastern Europe. This is a topic that Pallavi has researched. There we are going to hear some specific data and comments about the condition of air quality and its health effects in Bulgaria. За Zemiata also works in regards to improve public health. One of our main motivators is not only to have better environment, but also to have a healthy environment. We are not doctors, we are not epidemiologists, but our job is based on the idea that we should breathe healthy, clean air. This is the reason why we organize such webinars. Those of you that have joined us in Zoom, you will be able to give us your questions in the Q&A function of Zoom. If you have any questions, if you would like to comment, please write it there and use this function. Those of you that have joined us via YouTube and Facebook, please send us your questions as comments there. My colleague Ivailo Popov, who is also from the air team of Zemiata, is going to monitor all your comments, all your questions, and will help us send them to our panelists. We have several people who are helping us. We have interpreters who will interpret into Bulgarian and into English. So you can actually use the language that you feel comfortable with. Those who are here on the panel, I suggest if you would like to take the floor, please raise your hand, use this function of Zoom. I think this is all I wanted to start with. We are going to start with Hannah Bogart and her introduction. Then we're going to have some time dedicated to questions, answers, and comments. Then we're going to hear the presentation of Pallavi. We're also going to have time for questions. We should finish before 4 o'clock, but we'll see how it goes. And with this, I would like to give the floor to Hannah. I suggest...
Thank you, Dragomira. Thank you so much. Do you hear me?
Yes, we hear you.
Super, all right. So I'm going to share my screen. Give me a second here. So how is this?
It looks great.
Do you see this?
Yes, we can hear you very well as well.
I think so. All right. All right. So thank you so much for this invitation and really for the kind introduction. Let me jump right in. I'm Hannah Bogart, principal scientist at the Health Effects Institute and based in Boston, the US. For those unfamiliar with HEI, we are an independent research organization and provide high quality policy relevant science on the health effects of air pollution. And we get funded both from the US government as well as industry. and we are structured to maintain independence. And although we provide policy relevant science, we do not take policy positions. Now, you may be familiar with this earlier HEI report published in 2010 about traffic and health. There are detailed chapters in this report on emissions, on exposure, on toxicology and epidemiology. And at that time, a panel considered that there was evidence that was considered actually sufficient to support a causal relationship between traffic-related air pollution and the exacerbation of asthma. Only suggestive and or limited evidence was reported for all the other health outcomes that were looked at. Now, of course, a lot of things have been changed in the meantime. That's exactly why we started a new review in 2018, a systematic review this time around. Many new papers have been published. A lot of new regulations have taken place. Vehicle technologies have advanced. Emissions are declining in many high-income regions at least. And there's much more interest these days in the non-tailpipe PM emissions as well as in traffic noise. So this new report has been recently published a few months ago. And we also have a short summary paper published in Environment International. You'll see here the content of the report. It's a huge report, more than 600 pages. So for today, you know, I'm going to give you a snapshot of this report. Now, of course, this is all a team effort. We worked with a great expert panel chaired by Francesco Forestiera and Fred Lerman, many experts in epidemiology, in exposure assessment, and in statistics. We also worked with some consultants to the panel, as well as a contractor team that did all the searches and the data extraction. And of course, also a lot of people at HEI were involved in this. Now, we've developed a review protocol. It's online for everybody to see. We've used standard methods. We summarized the results quantitatively where possible using meta-analysis techniques. We included an evaluation of the risk of bias in individual studies using a tool that was also used for the reviews that are underpinning the WHO global new air quality guidelines. And at the end of the day, we reached conclusions about the confidence in the evidence. So some important methodologic features of the traffic review I would like you to be aware of. So this is the largest effort to date. Nevertheless, because the research field is so large, the panel needed to make some painful decisions in terms of what to focus on. So in this review, we focused only on the epidemiologic literature, and we focused on a selected set of health outcomes that were chosen a priori. It includes some mortality outcomes as well as some morbidity outcomes. Notably missing in this list here on the slides are the neurologic outcomes. We have looked at those, but not as systematic as the other ones. But we have separate chapters on those neurologic outcomes in the special report, but I'm not going to talk about them here today. So an important feature really is that we focus only on traffic-related and air pollution studies. I will come back to this new exposure framework in a second. And we assess the confidence in the evidence for an association using two complementary methods. with the ratings very low confidence, moderate confidence, or high confidence. So a few words on the exposure framework. So a key feature is the selection of only traffic-related air pollution studies. And by the way, we focus only on long-term exposure studies. Now, the exposure assessment of traffic-related air pollution is a challenge. It is difficult. Traffic-related air pollution is a complex mixture of many gases and PM. And it's characterized by high spatial and temporal variability. The other issue is that there is still no pollutant specific for traffic sources. And the other challenge is that traffic-related air pollution impacts at different scales. It is not only the near road environment that is impacted by traffic-related air pollution. It travels, right? It travels also to the neighborhood environment, the urban environments, and even beyond that. So we developed this new exposure framework where we were able to assess in a transparent way when we considered something a traffic-related air pollution study or not. It's based on a selection of traffic-related pollutants, it's based on exposure assessment methods, and it's based on the spatial resolution of the exposure model and also the spatial resolution of the health data. So a few words on the confidence assessments. So to get to this overall confidence rating for traffic-related air pollution, we've used two approaches. First using OHAT, and I'll come to OHAT in a second, but there were separate assessments for each exposure outcome pair by a study design. That was averaged for each exposure outcome pair. That was done for each health outcome. And then in addition, a narrative assessment was conducted for each health outcome, and that together was combined in an overall confidence rating. Now, on the modified OHAT approach, the idea is that there is this initial rating based on study design features. You'll see those study design features in the gray box here. And then there is up and downgrading based on certain factors, such as downgrading based on risk of bias. And there is upgrading based on, for example, exposure response or consistency. Now, in original grade guidance, all observational studies start at a low moderate confidence level. Now, OHAT decided that also prospective cohort studies could start at a moderate confidence level, whereas in the traffic review, we decided that basically all cohort studies, as well as case control studies, can start at a moderate confidence rating, because basically, 3 of the 4 design features that are in this gray box here were often met for those studies. And basically the only design feature that was not met, that's the controlled exposure feature. And of course, that is the only feature that can only be met by random controlled trials, basically. So the panel deemed it necessary to accompany this great type approach with a broader narrative assessment. The panel was convinced that this great approach remained imperfect. The application was very challenging, partly due to this mechanistic up and down grading of confidence related to certain factors. Other reasons to develop this complementary narrative approach was also because great type approaches, they focus really on the quality of a body of evidence, not necessarily on whether there is an association or not. And the other issue is that those grade assessments, they are heavily geared towards studies entering a meta-analysis. Now, we all know that that is often a subset of studies in a systematic review. So next, I'm going to show you some results. Again, it's a snapshot, really. I'm sure you can appreciate that the report is huge with so many outcomes and with so many pollutants. So we searched the literature starting in 1980 all the way up to July 2019. So the start date, January 1980, was the same as the earlier start date of the HCI 2010 traffic review. And after a broad search, we included about 350 studies in our systematic review. So 350 studies met our inclusion criteria. And about half of them entered a meta-analysis. Now, in addition, we identified 69 studies for neurologic outcomes. And as I mentioned, separate literature reviews were done for those outcomes. So respiratory outcomes in children, as well as birth outcomes, were the most common health outcomes that were studied. Fewer studies investigated respiratory outcomes in adults, cardiometabolic outcomes, and mortality. And most of the studies were published after 2008. So 2008 is the cutoff date of the earlier HCI traffic review. So basically, most of the studies were relatively recent. So in terms of the geographical location, so the majority of the studies were done in Europe, particularly Western, Northern, and Southern Europe, and North America. Studies in Asia, predominantly China, emerged more recently. Clearly, there are more traffic-related air pollution and health studies needed in low and middle-income countries, including studies in Central and Eastern Europe. I think there was only like one or very few studies available from Bulgaria, actually. So in this figure, you'll see the number of studies by outcome and pollutants. So NO2 was the traffic-related exposure indicator that was most widely used, followed by elemental carbon and PM 2.5. Also, about half of the studies, they reported on indirect traffic measures, such as distance to roadways or traffic density measures. And although those studies are informative, the panel could not combine them for use in meta-analysis because of all the varying definitions. Of note here also is that there were very few long-term exposure and health studies identified for some pollutants, specifically ultrafine particles and non-tailpipe PM indicators. And such studies were identified as a future research need. A last note is that many of the studies we included, they reported on more than one exposure metric. And of course, when they met the exposure framework, we extracted all that information. So moving on to some of the meta-analyses conducted. I have 4 slides of meta-analyses for now. So this is the first one. This is a forest plot for NO2 and all-cause mortality. You'll see here that we identified 11 studies in total. You'll see here the individual risk estimates, as well as the summary estimate in bold. Basically, almost all individual studies reported a positive association between NO2 and all-cause mortality. And the summary estimate is also positive, and as well as statistically significant. Now, this is a summary plot with all the main meta-analyses conducted for the outcome all-cause mortality. So not only NO2 that I showed you before, but also for all the other pollutants that we had enough studies for to conduct a meta-analysis. So the summary estimates, they documented positive associations between all the traffic pollutants and all-cause mortality. The point estimates ranged from 1.01 for copper to 1.06 for PM10 and iron. And the summary estimates for NO2, for elemental carbon, and PM2.5, basically the pollutants with most of the studies, more than 10, were all statistically significant. So 2 important notes before we move on. So those individual estimates, they are considered as indicators of traffic-related air pollution. So basically those different estimates, they are not independent from each other. The other note is that the effect estimates cannot be directly compared across the different pollutants because the selected increments can differ from place to place. So that's also an important consideration. Now, another meta-analysis, basically this is a plot with the same information as the earlier plot on all-cause mortality, but now adding also some other causes of death, including circulatory mortality and respiratory mortality, and then only for the pollutants that we had most studies on. So bottom line, similar positive associations were seen for the other causes of death, in particular circulatory mortality as well as ischemic heart disease mortality. The number of studies were typically lower for lung cancer and respiratory mortality, and you'll see also that the estimates are less precise. So this is my last slide in terms of some of the meta-analyses we conducted. This is a similar plot as before, but now for some of the morbidity outcomes. So you'll see here some birth outcomes, you'll see here some respiratory outcomes, and you'll see here some cardiometabolic outcomes. I know it's a lot to digest. So for now, let me say the following. The story is more complicated for some of the morbidity outcomes compared to the mortality outcomes. Typically, fewer studies were available, and especially there were few studies for the cardiometabolic outcomes, and possible outcome misclassification was identified as an issue for some of those cardiometabolic outcomes. For respiratory outcomes, the strongest evidence was found for asthma onset in both children and adults, as well as in acute lower respiratory infections in children. And basically studies examining NO2 made the greatest contribution to this evaluation. Now, for birth outcomes, most evidence was found for a positive association for term low birth weight and a small for gestational age. Now, notably consistent positive associations were reported for PM2.5, and basically associations for the other pollutants, including NO2 and elemental carbon, with the birth outcomes were essentially a null. So this is basically the last step in the systematic review, looking at the full body of evidence, focusing on all the pollutants and as well as the indirect traffic measures collectively for a given outcome. So basically the findings, they provided a high level of confidence in an association between traffic-related air pollution and all-cause mortality, and circulatory mortality and ischemic heart disease mortality. Also, the confidence in the evidence for an association was moderate to high between traffic-related air pollution and asthma onset in both children and adults, as well as in acute lower respiratory infections. And basically, the evidence was considered moderate or very low or low to moderate for all the other outcomes that we have looked at. And some of those outcomes did not even make it to this plot. So some key observations before wrapping up. This new review has 3 times more studies than the 2010 report. Though of course a direct comparison is difficult because of the difference in scope. Basically, half of the total numbers of identified studies, they enter the meta-analyses. The most common reason for a lower confidence judgment was imprecision, most often for cardiometabolic outcomes, clearly pointing to the need for more studies on those outcomes. And the most common reason for a higher confidence judgment was evidence for a monotonic exposure-response relationship. On the risk of bias, most of the studies were rated either as low to moderate for risk of bias for all domains except for the confounder domain. So for the confounder domain, we had about 1/3 of all the studies that were meta-analyses, which were rated as high risk of bias. Now, of course, we did not downgrade in all those cases, only when the effect estimates of those high risk of bias studies differ substantially compared to studies with low or moderate risk of bias. Now, of course, the evidence is quite compelling for some of the outcomes. The panel also identified some opportunities for new research. There is this huge table in the report listing some of those research opportunities. I've touched on some of them already, but really there's a need for more studies on traffic-related air pollution and health in low and middle income countries, including Bulgaria. We need more studies on ultrafine particles. We'll need more studies on non-tailpipe PM indicators. Also, the review focused on a systematic evaluation of the epidemiologic evidence. You'll see in the special report that there is also sort of a succinct summary of the mechanistic evidence behind all this. It's a separate chapter, but it's not systematic and all that. So we think that it would be helpful if we had done that in a more systematic way. And that's exactly also why we refrain from words like causality or causal relationship or causal association in this report. Also, we focused on traffic-related air pollution primarily. Of course, there's some attention also to traffic noise, but really there is a need for more studies that also looked at sort of those spatially correlated factors that may be associated with traffic-related air pollution. And also there's a need to evaluate the fuller range of potential impacts on transportation and new mobility on public health. And there's this nice paper published a few years ago, talking about basically 14 intertwined pathways between transportation and health. So, obviously it does not only include like traffic-related air pollution here as the issue, right? There's also traffic noise. There's also issues with urban heat islands, climate change, greenhouse gas emissions, or just simply stress. And it's important to look at all those things collectively. Also, the panel identified some improvements in terms of the methods for systematic reviews and for methods in evidence syntheses. And I'm not going to talk about them now. Some of those I have touched on. it's important when you do this systematic review that you include all the relevant studies in evidence syntheses, beyond the subset of evidence included in meta-analyses. A factor what is very important to consider is consistency. So you look at whether there is consistency of associations across study designs, across populations, and exposure assessment methods. And of course, this consistency, it can either, weaken the evidence, the confidence in the evidence, or it can strengthen the confidence in the evidence. And finally, we used a risk of bias tool that was also used in the systematic reviews underpinning the WHO new global air quality guidelines. Now, there is no consensus about, which risk of bias tool you should use. There are issues with all risk of bias tools. It's about the potential risk. It's not about an actual risk of bias in a particular study. And going forward, the panel, if we have to redo this again, is really calling for basically identifying and quantifying a few possible key biases, focus on what the direction of that bias may be, and calculate the potential impacts on those results. And this is my last slide with the overall conclusions. As I mentioned, the findings of the report have provided an overall high or moderate to high level of confidence in an association between long-term exposure to traffic-related air pollution and some adverse health outcomes, including some mortality outcomes, including asthma onset in both children and adults, as well as in acute lower respiratory infections in children. And the panel's confidence in the evidence was considered moderate or low or very low for all the other selected outcomes. Now, in light of the large number of people exposed, really the findings indicate that traffic-related air pollution remain an important public health concern and deserves greater attention from the public and from policymakers. So that is it for today that I would like to share with you. And thank you so much. Back to you.
Thank you, Hannah. Impressive work indeed. And I guess you have been working with quite a large team of people for quite a few years. But we were very happy to get the news in June, when we met with some people from the Health Effects Institute, that this report will be published, and you are finalizing it in June. So I guess you've been presenting it all around the world, and I hope that a lot of people get to hear about it, and a lot of policymakers get motivated and inspired by what you have been sharing and finding out based on this really how do you call this, extensive research. Maybe you can just say a few words of the people who have been working with you, just to tribute them as well.
Sorry, I really missed the question. I had issues with the with my I don't know what, with the interpretation button or something. Can you repeat it? So sorry.
No, I was just saying that really impressed by the amount of work you've done, and just wanted to ask you to shortly tell us about the team and how long you worked on the analysis.
Oh yeah, absolutely. So we started in 2018. So that is, I guess, a total of 4 years, and it's just a lot of work. That's the thing with systematic reviews, right? And we're not talking about like reviewing 20 studies or something. You'll see that also. We're talking about a huge systematic review with about 350 studies that we're trying to make sense of. We worked with a great expert panel But of course, they also have other jobs to do, right? So that's the other thing. Why of course sometimes it takes a little longer here. And I mean, we had also great help from a contractor team from Basel University. Meltem Kutla Josh, and you know, she was really great. So she did all the searches and developed this huge database, and basically extracted all the relevant information. So
yeah, well, thanks to all these people who supported and worked on the study. Just reminding and inviting all the people who are here in Zoom to comment by posting questions or remarks or any thoughts they have in the Q&A box that you have available for questions. If you want to intervene directly or contribute to the session, you can also raise hand and we'll be able to give you the opportunity to also speak. But please, first of all, use the Q&A option. And for the people who are with us in YouTube and in Facebook Live, you can ask your questions as comments under the streams. I have a few clarifying questions to you, Hannah, because as I said, probably most of the people who are on this webinar are not experts as you on epidemiology and on health effects. And some of the terms you're using are not familiar to me. And one of them is the all-cause versus circulational mortality. I was not listening to the Bulgarian translation. I don't know how this was translated, but can you just clarify what the two mean? Because I have not come upon them as well in our research.
Yeah, so all-cause mortality is basically deaths from all causes, so total mortality, whereas circulatory mortality or cardiovascular mortality is mortality only from cardiovascular causes.
Okay, I got it. So circulation. So it's called circular, meaning cardiovascular. Okay.
Correct.
Circular. Okay. Bringing the findings and the conclusions from the report to practice. Because this is a big issue now in Sofia and Bulgaria, how we measure traffic-related air pollution. And this is also related to where the official stations are situated, and what exactly do they measure. So from your practice and research, which pollutants shall we be measuring when trying to measure and assess transport-related air pollution? Is it enough to measure NO2 and PM2.5, or you would recommend a broader, like what are the essential, if you have to pick?
Yeah, you know, I mean, we all know that traffic-related air pollution is a complex mixture, right? That's what we're grappling with all the time. I don't think it's enough to measure NO2. I mean, so definitely include, if possible, at least elemental carbon as well as PM2.5. You know, that would be my recommendation.
Elemental carbon is black carbon? Or...
Correct. Yes. Yes. So what we, you know, in the traffic review, we combine basically elemental carbon with black carbon with sort of, you know, a sort of a soot measure. There are ways to combine that into one sort of elemental carbon metric.
Was this available as data in most of the studies? You were showing this in the beginning. But was this available in most of the studies? Also, the effects of black carbon, are they?
Yeah, we had. Yeah, thank you. You know, from the 350 studies that we included, most of them looked at NO2. But after that, it was actually elemental carbon that came in second. And then I believe PM2.5. You know, we identified, and I mentioned this before, very few studies on ultrafine particles. I mean, I would argue, that's also an important pollutant when talking about traffic-related air pollution, right? But very few studies were identified. That's a challenge, Remember, we looked at long-term studies. And of course, there are no routine measurements for ultrafine particles available, right? So it's all modeling and sort of research campaigns that try to include those pollutants. So.
Yeah, when you said that more studies are needed, especially in our part of the world, of course, this is the essence of research. You always need to have new studies and new understanding and upgrade it and enrich the understanding. But I also remember that Pauli and Dan stressed on this in the conference presentation of air quality and health, which we had in June in Plovdiv, that we have enough evidence. We have enough evidence for the policy action. So when you say more research is needed, do you mean that more research is needed on traffic and health effects to motivate policy action, or we have enough evidence for decision makers to act?
Thank you for this great question. Let me be very clear. We have enough evidence to act, right? We know that traffic-related air pollution causes many, many health outcomes. I've tried in my talk, and actually also the report is very clear on that the evidence is compelling for some health outcomes, and that's enough in a way. But of course, as researchers, right, you will know that there's always additional things that we can study, but definitely there's enough to act now.
I have one final question, and I'm not sure, Hannah, if you'll be able to answer, but this is a question which we get all the time from the people who follow us, or from people who question what we communicate, and it's about the different effects or the effects from transport-related air pollution on the different type of participants in the mobility function of the city, be it the effects of the passengers, cyclists, drivers, or residents who live on very busy roads. I'm not sure if this appeared in the studies, and this was definitely not the focus of the research you were doing, but if you can comment on this, are these effects different? And if yes, which of these groups are more vulnerable compared to others?
Yeah.
And I'm not even talking about elderly people or children who are also all of these.
Yeah, thank you. In our review, there's the focus on long-term exposure to traffic-related air pollution. And basically what it means is that most of the epidemiologic studies, they estimate the exposure at the residential address. So basically, at home, or outside their homes. So, what's not included in basically most of the epidemiologic studies is indeed the additional exposures coming from when you're in traffic. We know that when you're in traffic, when you're commuting, that your exposures can be substantial. Now, of course, it's only a short amount of time, right? You're not traveling all day, hopefully, right? It's only like, half an hour or whatever. So, what it really means in sort of in terms of your average exposure, that is, hopefully not as much, but it is definitely substantial. There are some studies that indeed have looked at what those commuter exposures means in terms of health outcomes. No, those studies most of them are focused on short-term exposure and health outcomes. So basically measuring lung function or like measuring, maybe some blood markers and all that. And there's definitely evidence that show also short-term effects of those short-term exposures. But that was not the focus of this current review. So I hope this helps a little bit, probably not so much.
Yeah, I would invite any of the panelists if they have any questions or comments to Hannah, or even if there are questions from YouTube or Facebook which you want to share with us.
No, for now we don't have any questions.
Okay, well, Hannah, thanks a lot. Thank you very much. I would be happy if you're able to stay with us also for the talk from Pallavi, and I guess there might be some further questions. There is a question that we are getting now, and it's in Bulgarian. I would be happy if the interpreters can translate it into English for Hannah. I think the question is for Hannah, as it came right now. Hannah, are you getting a translation?
Now, this is the question. For someone who is not a scientist, can you hear me now? For someone who is not a scientist and does not meet such graphic data quite often, I mean the graphics that show the relative risk, what exactly do these coefficients mean? For example, if we have 1.5 positive, does this mean 5% increased risk or not?
That is exactly what it is. Yes, you're all correct. Yes, the relative risk is, for example, the estimate of 1.05. That's indeed a 5% additional risk of, in this case, dying.
Thank you, Peter, very much. I was also meaning to ask and clarify what exactly that is mean, but Hannah, thanks also for taking the question and answering. Okay, I think that's all for now. If any other questions occur, you'll be able to ask them after we have the talk from Pallavi. And Pallavi, if you are ready, we can have you as a speaker now. And you can also say a few words about the study, and probably the Health Effects Institute was very well presented by Hannah, so maybe it will be just on the study. Thanks, Pallavi, over to you.
Thank you, Draga, for organizing this event and for giving us the opportunity to share some of our data. And I'm really glad that Hannah went before me and talked about a lot of the epidemiological evidence that we have related to traffic air pollution. And some of the work that we do at HEI tries to take that type of evidence and information and make it a little bit easier for us to communicate and use this data more widely. And before I go any further, I would like to thank some of our collaborators that have been involved with the work that I will be presenting today, especially Dr. Angel Jambok, who's been a very close collaborator over the last 1.5 years as we've done some work on air pollution and health in Bulgaria, and also some other colleagues, both from research and academic side, and also from civil society groups, including Zemiata. We've learned a lot from all of you, and hopefully we can continue with these discussions and work towards cleaner air for all. So the work that I will be presenting today is coming from our State of Global Air initiative, which is also based at the Health Effects Institute and tries to go one step beyond what Hannah was talking about today. She looked at and presented evidence on how traffic-related air pollution can affect our health. That data and that information comes directly from a lot of epidemiology studies. And learning from those types of studies, we can go one step forward and look at what the broader health impacts might be, how many people might die as a result of exposures to air pollution, how that might impact people that live with chronic diseases, etc. And for the last several years, we have been producing global reports that we call the State of Global Air, where we present very large-scale data on air quality trends, health impact trends in countries around the world. And we do this work in collaboration with the Institute for Health Metrics and Evaluation. We've been working with them for a very long time. And a lot of the data that gets used in the reports is based on the Global Burden of Disease Analysis, or the GBD, which is essentially a risk assessment framework. So if for any given location, we were trying to determine whether air pollution or smoking or blood pressure or sanitation might be the biggest driver for health impacts. And what I'm going to do today is focus a little bit specifically on Bulgaria and on the Southeast European region, drawing from some of these results. I think for anyone who is listening in right now, this is not going to be news, but a lot of the people around the world live in areas with dirty air. In fact, about 50% of the population is in areas that do not even meet the least stringent interim target, which is 35 micrograms per meter cube annually. And if you look at this map, everything that you see in yellows and reds are areas with higher levels of air pollution. And we definitely, see and hear a lot about the problem of air pollution in South Asia and India, especially also in China and East and Southeast Asia. But if you look carefully, even in the region that we're focusing on today, the air pollution levels are not as low as they are in other parts of the world. And if we take that same approach and we start looking at cities around the world, so not focusing on entire countries, but just looking at individual cities, similar trends show up. We see cities in parts of Africa, in parts of Asia, with really high concentrations. And again, here the yellows and the oranges and the reds correspond to higher concentrations of PM2.5. And several cities in Southeast Europe as well have relatively high levels of PM2.5. NO2, which is another pollutant that Hannah talked about, very closely linked with traffic-related air pollution, the trends are actually quite a bit different. So in this case, we see that even though the levels are higher in parts of Asia, it's actually Southeast East Europe, as well as Central Asia and the Middle East and Northern African cities where the levels can be very high. So there's definitely differences in the patterns of exposure depending on the pollutant we're looking at. PM2.5 can tell us one story, but another pollutant like NO2 may tell us a completely different story. And there's a few examples even from within Europe where we know that even though the PM2.5 levels are not very high, NO2 levels can often exceed limit values in certain places, and we are looking for solutions to address NO2 pollution, especially in urban areas. So starting to move from the global scale to a somewhat more local scale, if we look across the European Union and we look at the capital cities, Sofia, unfortunately, experiences the highest PM2.5 exposures. And if we continue to follow through, we see that countries in Eastern and Central Europe, including Poland, Hungary, Czechia, Romania, are all in the top 5 to 7, with capital cities having very high exposures to PM2.5. When we compare it with the WHO guideline, of course, most capital cities exceed that level of 5 micrograms per meter cube. And even though on average, cities might be meeting the EU limit value, those exposures are still really high. And now going from Europe into Bulgarian cities specifically, I have a few examples here just from across the country of trends in PM 2.5 over time. So looking back to 2010 all the way to 2019, what do we see is happening? And as you will notice here, Plovdiv emerges as the city with the highest exposures, followed very closely by Sofia, and then Varna and Burgas tend to have relatively lower exposures. But again, in your mind, if you sort of try to draw a line at 5, we are all a lot higher than where WHO considers it really, where the levels should be. But these are annual average exposures, which is, we're looking at air pollution or PM 2.5 trends throughout the year, and then we are averaging out so that we can get one value for every year and look at the trend over time. The good thing is that the values are not going up pretty radically. And in fact, if we look back at even longer time periods, so starting in the 1990s, we know that across Bulgaria, the levels of PM 2.5 are going down. But we are about to enter the winter season, which is when air pollution is often very high. It's very visible. And if we look at data that has been collected by the Bulgarian institutions looking at PM 2.5 levels throughout the year. So the x-axis here goes from January through December, looking at what the levels of PM 2.5 are in each month. We see extremely high concentrations going almost 2 times or even more higher than even what the EU air quality limit value is. In months of January, also in months of December in some cases, and then gradually over the next few months, the concentrations start to come down. And during summer period, we see the lowest levels of exposure. So as you can imagine, this is what we see month to month. But then when we try to average out, we land somewhere in the middle with one value for annual average exposures. And if we compare this with cities in other countries around Bulgaria, we again look at capital cities, not necessarily all members of the EU, but Skopje, which is again a lot in the news, especially in winter for having really high levels of PM 2.5, Sarajevo, Belgrade and Bucharest, we see again very similar trends that levels are not really going up, but they are not as low as we would like them to be. And as Hannah talked about briefly, air pollution exposure and especially PM 2.5 exposures can have a variety of health effects on humans. And these can be both short-term and long-term. So short-term could be anything ranging from a few hours to a few days. Think about, the exposures we were just discussing when you're out, going from place A to place B, or exposures at a time when there may be an air pollution episode, versus long-term exposures, which are over months and years of time. And these long-term exposures are what we know to cause the largest health impacts on humans. And this can include lung diseases and heart diseases, but also other chronic non-communicable diseases like type 2 diabetes or lung cancer or stroke. We have a lot of evidence now that exposure to pregnant mothers can result in a variety of health impacts on the newborns. And also, as Hannah pointed out, evidence that exposure to PM 2.5 can be linked with diseases like dementia, and continuing evidence on other types of diseases and organ systems that may get impacted by exposure to PM 2.5. But this is evidence we have from around the world. There is also a growing body of evidence in Bulgaria that is being led by researchers at medical universities and at other universities as well. I've picked here a few examples just to highlight the kinds of evidence that is being reported, including a very recent study which found that at times of high PM 2.5 levels, we see an increase in lung disease related hospital visits, a greater call for ambulances when the peaks in air pollution happen most often during the winter season. And similar studies in other places have found very similar results, that during peak air pollution exposures, we can see increase in hospitalizations, more emergency visit departments, and for people who may be living with chronic diseases, especially respiratory diseases like asthma or COPD, they may experience an exacerbation of symptoms during these times. And in fact, in different cities in Bulgaria, two separate studies found that there may be aggravation of COPD symptoms and even more hospitalizations for COPD patients during times of high PM levels. Now, some of these studies have been done for PM10 and not for PM2.5, but they're consistent with the global evidence that exists. Another study, which was led by Dr. Jambal, who's also our collaborator, found that exposure to PM2.5 and also polycyclic aromatic hydrocarbons, or PAHs as we more commonly know them, was associated with type 2 diabetes, another chronic non-communicable disease. And this is just a snapshot of the evidence. There are other studies in Bulgarian cities that have looked at how air pollution affects health. And we have a compendium available on our website that you can browse through to find other studies that may be looking at cities where you may be currently living in. And I think another point related to the health impacts across the European Union, which has been made a lot of times, and we see this in our data sets as well, is that there are differences in how countries across the European Union experience health impacts related to air pollution. This is partly to do with the very high levels of air pollution and the types of sources we have, including greater use of solid fuels and fossil fuels for heating, especially during winter season, power plants that are linked to coal consumption, industries that are centered in the region, and also the fact that the vehicles can be older and therefore more polluting, not as clean as they may be in other parts of Europe. So these are all important things to start thinking about when we look at the differences in both exposures and health impacts across the region. Coming back now again to Bulgaria and focusing a little bit more on the health impacts, air pollution is currently the 7th leading risk factors for deaths. There are a variety of other risk factors which rank higher, but these are some of the factors that we're more commonly aware of, things like smoking and higher blood pressure, higher cholesterol that we associate with poor health in general, but air pollution being in the top 10 is, an important thing for us to take into account. And a lot of these deaths that happen across Bulgaria are linked with outdoor PM2.5 exposures. When we look at individual diseases that have been connected with air pollution, we have a lot of evidence for globally. We find that in some cases, especially diseases like COPD, almost 20% of all COPD deaths in 2019, in one single year, 20% of all COPD deaths were linked to air pollution, or 16% of lung cancer deaths were linked to air pollution. So this is a substantial contribution, and therefore, something important that we need to keeping in mind and pay attention to as we plan public health policies, and also as we plan the air-related policies. Another concerning factor to keep in mind is if we look at countries across Southeast Europe, this figure has very small labels, so please don't mind trying to read what's on the axes. What I really want you to focus on is the red line, which is right at the top. That shows the trend of death rate. So how many deaths happened for every 100,000 people in Bulgaria? The red line is showing us that trend. In 2019, this was about 159 deaths per 100,000 people. And the black line that you see at the very bottom, that's the EU average. So we see that Bulgaria not only has the highest death rates linked with air pollution across Southeast Europe, but these levels are also significantly higher than what the EU averages are. And even if we look at global averages, the global average is somewhere around 86 deaths per 100,000 people. So significantly larger, death rate in Bulgaria. And that also then, connects to what we see at the city level, because in a recent report that we published looking at air quality and health in cities around the world, we looked at about 7,000 cities from every region, and we found that Plovdiv had the highest death rate of all the more than 7,000 cities. So that's a pretty stark, stark number and a stark figure for us to be thinking about. But all this time, I've talked a lot about, air quality data and trends and how we can look at trends over time. An important question that this often leads to is, how are these numbers being produced and where are they coming from? And there's 2 or 3 different components to getting to these final burden numbers, or when we say 11,000 deaths or 159 deaths per 100,000 people. And the first part of that is understanding what the exposure patterns are. And because we know around the world that we do not have sufficient ground monitoring data, not every city, not every country is monitoring PM2.5 levels, we combine data from different sources. So we combine the ground monitoring data, which can come from stations that have been set up, and we also look upwards and combine with the ground monitoring data, the satellite-based data that we can get for year after year for the past several years. And then using atmospheric models, what are known as chemical transport models, we can start to generate what the PM2.5 levels might be. We can also do this for other pollutants. And using a combination of these different data sources, we are able to say what the exposure levels are at the national level, what the exposure levels might be in individual cities and individual regions. And as you can imagine, because we are combining different data streams, the uncertainties or the errors in the data are going to be higher in places where we have fewer monitoring stations compared to places where we have a lot of monitoring stations. We know exactly what the levels are on the ground. So that is one part of what goes into this analysis. The second part is a lot of what Hannah was talking about earlier. So epidemiology studies often look at a particular air pollutant and how that affects a specific health outcome. So we could be looking at PM2.5 levels and the risk of lung cancer, or the risk of diabetes, or the risk of COPD. And those studies inform what we call the concentration response relationships or functions, where we can say at a certain level of air pollution exposure, this is the risk we expect to see. And there are a few other steps in between, some of which are sort of modeling based, that then allow us to say what the burden of disease for a particular country, for a particular city might be. And there are many ways that people come to these estimates using different types of exposure data or air quality data, using some combinations of health studies, and finally understanding what the burden of disease might be. But another thing to really keep in mind is that the health impacts of air pollution are driven by multiple factors. And of course, air pollution exposure is a key component. Higher exposure will often result in bigger and larger health impacts. But a second really important component is what the demographic patterns and trends are. So for example, across our population, how many older people and younger people do we have? And this is sort of going back to the point I was making earlier, that long chronic diseases, and these diseases take time to develop. So we're more likely to see them as people get older. And therefore, in countries or in cities where we might have more older people, we're likely to see, a different sort of number of deaths that are related to air pollution. So as we also think about, on the flip side, how can we reduce air pollution to improve public health, we have to keep in mind that, yes, we can improve air quality and it will improve public health, but it's not going to be a one-to-one relationship. And there are also other factors that can play into this, including who has access to healthcare, how easy is it for them to access healthcare, do they have screenings for certain diseases, which makes it easier for you to pick when someone, might be experiencing symptoms. And also as countries develop and some of the sources of air pollution change, we can see that influences both the quality of life that people have. It can, affect how people access healthcare. It can also affect how stringent some of the emission reduction approaches are or where they're being applied. So it's a confluence of all of these different factors that really results in the health impacts that we see for any given country or for any given city. But it is not all doom and gloom. We continue to make progress around the world and also in Bulgaria. And I do want to end on a more hopeful and positive note. And if we look back since 1990, so almost 3 decades, air pollution emissions have been declining consistently across sectors, whether we look at energy, whether we look at on-road transportation, industry, waste. All of these emissions have been slowly declining, which means we're putting less pollution out into the air around us. However, we should still be focusing on sectors that have a huge impact in what air pollution levels we do see. And in case of Bulgaria, the residential sector, especially residential fuel use, as well as road transportation and energy production are the 3 largest sectors that play a role in contributing to PM 2.5 levels. And a point I wanted to note from a study that was done for Sofia, published very recently, just last year, that for PM10, which is one of the pollutants we look at more broadly, transport is the dominant source within the city and the central area, as well as around roads that have heavy traffic. And this is not just in colder winter season, this is also true in the summer season. So as Sofia looks to implement low emission zones, which will address both heating and transportation, I think we will see some progress in terms of what the air pollution levels are. And it's also very encouraging that there are a variety of efforts that are trying to focus the attention on air pollution, whether it is community monitoring programs that have been ongoing. I have the snapshot here from Air Bulgaria website, which has low-cost monitors in different places, and communities have been using these data, trying to understand what the exposures are for them and in their communities. Draga already mentioned the low emission zone a little bit, and we'll wait and see how Sofia implements the low emission zone and what benefits might come from it over time. And another really useful development that has happened in the last few years is that the medical experts, the doctors, the clinicians, the nurses are getting more involved in conversations related to air pollution. Even within Bulgaria, organizations like Air for Health are trying to bring medical experts together to focus on this issue of air pollution, how it is impacting the health of the people, the health of their patients, and finding ways to communicate more about it and demand for cleaner air. So I think there is a lot of reason for hope and using these data constructively to continue to make progress both at the city level and at the national and regional levels. And with that, I'll thank you all for joining us today, and back to you, Draga.
Thank you, Pallavi. Thanks for combining all 3 studies in your presentation and contribution. And definitely great that you also pointed to the work with the Plovdiv Medical University and the contribution of Angel. And I'm really hoping that you'll be continuing to work together, and you made a statement that you will. So I hope that you manage to develop some interesting projects and proposals and get support for the work to continue. I think Angel is also among us in the attendees. So Angel, if you want to add anything or comment, ask questions, please do so, either by typing your question in the Q&A or raising a hand, and we'll be able to give you the opportunity to speak. Pallavi, some questions from my side. before I pass to the attendees and people in YouTube and Facebook. Maybe first to say that there was one question while you were speaking, which was related to the slides from the presentation, and I answered that we'll have the PDFs with your presentation, so we'll be able to share with the attendees and they can look back to the content which was shared and also use it, because most of the graphs are content which is freely available to use. Please confirm if
Yes,
or oppose if it's not the right thing to say. Yeah, but I was quite surprised by the graph in Skopje, which you showed, because most of the graphs had a very similar profile also for Sofia, Plovdiv, Varna, Burgas, other capitals on the Balkans, and Skopje was clearly outstanding by a steady decline even after 2019. Do you have an idea what is this related to? An explanation for?
No, thank you for.
This was the PM 2.5.
PM 2.5. Yeah, it's actually, I can share what I know, but if there are other people here who are more familiar with what's been happening in North Macedonia, I would welcome their input as well. But I think in the last few years, a few different things have happened. One, with the engagement of several different international organizations, North Macedonia has been thinking more clearly about air quality management. They released a plan, I believe in 2019, or it may have been, in 2018, with very clear ideas on which sources they would like to address and how that would happen. There has also been a shift away from fossil fuel-based energy generation and a greater focus on renewable energy. And as you would appreciate in all countries, power plants and especially coal-using power plants can have a very big influence on the levels of PM 2.5. So if we have big power plants close to cities, we will see that there is some contribution from them. So I think for Skopje directly, there may be other explanations for this as well that I'm not as familiar with, but there is definitely a greater focus on moving towards cleaner energy. There is, a very clear plans on how to address air quality within the city and more broadly across the country, which is now being implemented. It would actually be very interesting to see what happens in the next couple of years and, whether that momentum continues and whether all of those policies do get implemented. But despite that, I think, Skopje still has a long way to go given where the PM 2.5 levels are. So hopefully that downward trend will continue forward too.
I really appreciated the comment and recommendation you had on one of your last slides on the demographic factor, and having it in mind when addressing air pollution and exposure to air pollution and designing policies and actions to address air pollution and exposure. And this is something definitely which is relevant for Sofia and most of the Bulgarian cities, big Bulgarian cities as well. And I was wondering if you have some specific ideas in mind or examples in mind of what other cities are doing when they have demographic centered measures to address air pollution in the cities.
Yeah, I think for the most part, as far as I'm aware, the efforts to improve air quality tend to focus more on what the major sources are. And what we have seen from examples around the world over time is that it really is that component of identifying what the biggest sources are and then steadily focusing on them consistently, not one-off measures and not one-off policies, but consistently staying on target to try and reduce those. I think knowing that there may be populations that are more vulnerable to the effects of air pollution in certain cities or countries, there could be more targeted awareness campaigns to help people realize, how air pollution exposures can impact their health, if there are simple and easy ways for them to reduce some of these exposures. And one example, which is not necessarily for like focusing on the demographics, but in Indian cities in the last couple of years, one of the major public health messages coming from the, a lot of different places is that during winter season, when pollution levels are really high, do you still go for your morning walk at 6 in the morning when the pollution, PM 2.5 levels tend to be extremely high, or do you do that in the middle of the day when they will be relatively low? So there are also some public health messages drawing on these data, which can be very, very simple and can be aimed at reducing exposure, especially for those that are most affected. And another thing that can help from the demographic and health perspective is enhancing the surveillance programs for diseases that we know are linked with air pollution. Often countries would have, surveillance registries or other types of ways to monitor people who have COPD or lung cancer. Are we thinking about air pollution related information when those registry, data are collected, and can we do that? Because ultimately, one of the things that Hannah was pointing out, and the evidence that I showed from Bulgaria has so far largely focused on shorter term exposure. So what would really be beneficial is over time, just to add more evidence and more information in the local context, if we could do studies of long-term exposures of air pollution. So I think there's a mix of some strategies which could be very communications focused and some which could try to change our public health approach that could hopefully be helpful.
Thanks a lot, Pallavi. We have some questions or comments also here in the Q&A session. Angel says hi. I can read out what he's saying. I was just thinking we need better ways of communicating the rather gloomy evidence on health impacts of air pollution, as lay people don't often realize the magnitude of the problem or feel it viscerally enough as a problem of theirs. And he continues, so events as this one for expanding knowledge on the subject in a digestible way are commendable. Yeah, definitely. So, Angel, I agree, and definitely also trying to get the policymakers on board. Luckily, we'll have these talks recorded, and we will further distribute them so more people will be able to listen. And definitely thanks to Hannah and Pallavi to bringing all this high-level research and scientific information to a very understandable language and level, which Pallavi and Hannah are definitely very good at. From Peter, probably a question to Pallavi. Do you have data about how much time does it take to develop some of the health effects? What exactly means long-term exposure, in fact? Sophie is considering limiting burning in the households, burning of fossil fuels in households in 2030. There is a proposal to do this in 2026. Can we predict how harmful will be a 4-year delay for the public health of a city of 1.3 million inhabitants? Is asking Peter.
Thanks for this question. This is actually, yes, there are ways that we can look at what the effects might be if a policy gets implemented, if the policy gets implemented in 2026 versus in 2030. In fact, there's a major study that I didn't really discuss very much today, but that HEI has done to look at sources of air pollution. And when we did those studies in India and China, in addition to looking at sources today, we also looked at the future to say if, certain choices were made around energy supply and other major sources of air pollution, what would be the impacts on health? And in a similar framework, we could look at policy decisions that are going to be implemented at certain points in time, and whether doing them, in 1 year versus another, how much of a difference is that going to make? And Peter, I'm happy to, discuss more offline and also connect you with colleagues who do these types of analysis very regularly if you would like to, continue this and see what might come.
Thanks a lot, Pallavi. Peter is also part of the Zemiata air quality team, and yeah, he's working on our communication campaign. So definitely good if he will be able to get some information material that we want to, that will further communicate. So Peter, encouraging you to further explore and study the topic. Ivo, is there any question, comment from Facebook Live or YouTube?
No, I cannot see any for now.
Okay. Pallavi, can you more specifically name the study you were referring to when talking about PM2 contribution to air pollution in Sofia? You said that you referred to us. I cannot, from the top of my head, I'm not sure which one do you mean. So just to, if you're able, just to say it so that people can look at it if interested.
Yeah, so this was actually part of a global study that we did looking at sources of air pollution. And essentially, the way that the study was done is we looked at what the emissions of air pollution are in different parts of the world. And then, using atmospheric models, understand what the contribution of these different emissions is to PM 2.5 levels. So we have data for all of the countries around the world at the national level. And in one of the reports we published earlier this year, looking at air quality and health in Bulgaria, we included the results for the national level estimate. So I think there we saw that residential sources, energy production, industry, and agriculture are some of the top sources at the national scale. Transportation comes at about 7% of the total PM 2.5 at the national scale. But then we do have data for individual cities also that include Sofia, but also some of the other like Plevin, Plovdiv, Varna, Stara Zagora. But for the city level information, that data may not be, in the public domain in an easy to access way. So, it's likely going to be in a big spreadsheet and in the middle of like a lot of other data. So I'm happy to extract the part for cities in Bulgaria and share that when I send the slides over, so that you have a sense of, what those numbers are saying.
Yeah, that would be great. In fact, we have quite different data from the official stations and from the communication from the municipality, which is still communicating that the major source of PM10 pollution in Sofia is the residential burning. Mm-hmm. And second to that comes traffic and traffic-related sources of air pollution. So yeah, definitely we'll be happy to look into the data that you were referring to. Ivo, anything from your side that you would like to add or comment?
No, thank you.
Okay, well, final invitation to the people who are attending. Also, if you want to communicate anything to us or have a question on what has been shared either to Hannah or to Pallavi. I would be happy if Angel wants to jump in. Just before this, the webinar, we had a talk with a journalist from the Bulgarian National Radio from Plovdiv, and we were announcing the webinar on the Plovdiv station of the Bulgarian National Radio in one of the morning programs. And she was also sharing with us that air quality in Plovdiv seems to be unbearable in the last couple of years, and things are getting worse, especially with a very intense construction going on in the periphery of the city. And obviously lots of people moving to Plovdiv because it's been developing as a major economic center and trade center in the center of Bulgaria in the past, well, I would say 10 years, but really with a boom in the past 5 years. So yeah, the 7,000 cities review, among which Plovdiv ranks first in terms of death rate related to bad air quality, is a really grave and shocking statistics to me. And yeah, just wondering how Angel accepts and would comment. And Angel, we can raise it to your panelist if you want to jump in with a quick comment on this. I would ask the tech team to give you the opportunity to speak as well. I'm sure they'll be able to react.
It would be good to hear from Angel since he's here.
Yeah. Okay, he says sure. I guess you have to accept an invitation to be upgraded to a panelist so that we can get a contribution from you directly.
Hello again.
Good to see you, Angel. Hello.
Yeah, I managed to finish my lecture in time. So yeah, in this context, it's not so great for Plovdiv to be leading and on top of the list. So rather gloomy indeed. But in November, yeah, we have this initiative organized by Air for Health, specifically to like a roundtable to address the issue and kind of brainstorm some solutions how through urban planning we could target the air pollution issue. So maybe we should also look at it not simply as like an individual exposure, rather as a contextual one, and suggest to local authorities interventions through land use planning or whatever that would not just improve air quality, but also provide other affordances to people, like access to green areas and in general improve living conditions and so forth. And maybe that would make it a bit more appealing for them to consider it or invest resources, right? If they see that one intervention could actually result in a number of health benefits through mitigating various pollutants or providing restorative environments and so forth. But on the other hand, as a researcher, you know, it's also exciting to be living in such an area because it allows for further studies, and we've planned such. Hopefully we'll get funded and actually be able to derive our local exposure response function. So my feeling is that maybe with local data, it would actually turn out that these burden of disease estimates are underestimated, right? And in Bulgaria, it may turn out that we actually experience much greater burden from air pollution. So a lot of venue for research, but there should be a receptive side on the other end, right? From local authorities, from stakeholders. And it's absolutely wonderful that NGOs are so supportive and can supplement, the expertise, what may be lacking in local authorities and environmental health services. It's really a joint effort.
Absolutely agree. Thanks, Angel. Lots of space for initiatives and action and for brave policy actions. So yeah, let's not end with a gloomy perspective, but look forward to what is ahead from us and motivate policymakers with joint efforts to take the right measures for healthy air in Bulgarian cities. Ivo, any final notes from our participants in the other channels, if there is anything else that appeared meanwhile?
No, there are still not any comments or questions.
Okay. Well, I would close in this case the webinar for today. Thanks a lot to Pallavi and to Johanna for joining us and for taking the time to prepare and share the research that they have been working on. good luck definitely with all the coming studies and also with the collaboration with the Plovdiv Medical University. What we said is that we'll circulate the slides from both Pallavi and Hannah to the people who registered in Zoom as participants via email. And well, I would just end with a wish that the review of the Air Quality Directive by the European Commission goes in the direction of adopting the stricter WHO guidelines for air quality standards. And just in 20 days, on the 26th of November, we're expecting to see the first proposal that the Commission will publish. So this is definitely going to be a very strong signal and stimulus for policy makers on national and local level for more progressive and stricter measures. I'm sure all of you are following this process at HEI and probably also at the medical university. So something to work on and communicate on and unite efforts on. Thanks a lot, everyone. Have a good afternoon. And yeah, see you soon again. Thank you.
Thank you so
Goodbye.
much.
Thanks a lot.
Bye.